Hi, my name is Madeline Wood, and today is May 19th, 2020. I am going to be doing the Unit 4 case connection assignment today. I'm doing case number 1 and case number 2. So for case 1, urea cycle disorder, in this case, the first thing the doctor wants to figure out is whether this baby is suffering from a urea cycle disorder or a disorder involving beta oxidation. In order to figure this out, they should order a panel of labs that includes the patient's plasma glutamine levels. Urea cycle disorders are associated with elevated levels of ammonia, and plasma glutamine levels are rarely ever normal in the setting of hyperammonemia. For this reason, an elevated level of plasma glutamine would suggest an elevated amount of ammonia, which would be telling of a urea cycle disorder, and not a beta oxidation disorder. For the other three options that are not the best choices, the blood glucose would not be a valuable test in this case because often patients with a urea cycle disorder present with normal plasma glucose concentrations, but hypoglycemia can be a telling sign of beta oxidation disorder. But there are many other disorders that could cause this as well, so it's not the best answer. A beta oxidation disorder and urea cycle disorder can both present with abnormal levels of urinary acids. So for that reason, urinary acids would not be appropriate for distinguishing between the two. However, running a urinary acid analysis is beneficial for specifying the urea cycle disorder once the broad diagnosis has been made. Lastly, serum fatty acid levels would not be indicative of a urea cycle disorder. They can be used to diagnose a beta oxidation disorder, but it's not specific enough in this case. So, after the full blood workup came back, the baby is seen to have elevated levels of ammonia, elevated levels of orotic acid, and normal levels of plasma citrulline. So you see a normal level of blood ammonia is about 17 to 80. The patient was initially born with a level of 314, and that even rose up to 600. They also had a urine orotic acid level of 473, while the normal level is 0 to 3. And then lastly, for citrulline, the baby was born with a level of 10, and normal is 12 to 55. So that is considered normal. It's the low end of normal, but that's a normal citrulline level. So the urea cycle is responsible for clearing the body of nitrogenous waste, and it's the body's source of arginine, ornithine, and citrulline. Therefore, by testing the body's levels of these compounds, we might be able to figure out at what step of the urea cycle there is a deficiency. So there are 5 enzymes that catalyze the urea cycle. These are carbamoyl phosphate synthetase 1, or CPS1, ornithine transcarbamylase, or OTC, arginine succinate acid synthetase, or ASS1, and arginine succinic acid lyase, ASL, and lastly arginase, ARG1. So we know that a deficiency in any of these enzymes would cause the increase in ammonia levels. So we're not going to focus on the ammonia levels because any deficiency would cause that increase. So we're going to focus on the abnormal orotic acid level and then also the normal citrulline level. So this patient is least likely to have the deficiency in carbamoyl phosphate synthetase 1, or CPS1. So in a CPS1 deficiency, there is usually either trace amounts or no citrulline at all present. And in this case, the patient presents on the low end of normal for plasma citrulline concentration. So this leads us to believe that she would not have a CPS1 deficiency. Additionally, and most importantly, in a disorder of the CPS1, there's usually a normal or even a low amount of orotic acid present in the urine. And this is the most telling sign here that the patient's not suffering from a CPS1 deficiency because her orotic acid levels are extremely high. So the patient is most likely suffering from a deficiency in ornithine transcarbamylase, or OTC. This deficiency fits the most with her lab work. So orotic acid is significantly elevated in the urine of a patient with an OTC deficiency. And also, plasma citrulline levels are typically low or on the low end of normal for patients with an OTC deficiency. So we see that this is most similar to the patient that we are presented with. This OTC deficiency would also explain the patient's symptoms. OTC is an X-linked enzyme that catalyzes the synthesis of citrulline. Citrulline is synthesized from carbamoyl phosphate and ornithine. Because this enzyme is an X-linked enzyme, it's often less severe and less common in female patients. The deficiency is often fatal in males because they only have one X chromosome. Females with the gene often present with lethargy, trouble breathing, and controlling their body temperature, and even experience seizures or coma. And in the long term, this deficiency can cause liver damage and a developmental delay. So here are the resources for that. That was case 1. So now on to case 2. So for case 2, this is what we know about the patient. So the patient is a 4-day-old infant called patient A. Was born at a weight of 5.9 pounds after a normal vaginal delivery. After some blood work, patient A's phenylalanine or PHE levels were 6.6, and the normal range for this measurement is 1 to 2. From this, the doctors are able to diagnose phenylketonuria or PKU, but the family denies any family history of this. PKU is a recessive disorder that increases phenylalanine levels in the blood. Being recessive, it would make sense that there's not a family history of the disorder because both parents would have to be carriers of the trait and both pass along the trait to patient A. PKU is caused by a mutation of the phenylalanine hydroxylase or the PAH gene. PAH is responsible for converting phenylalanine into tyrosine, requiring the cofactor tetrahydrobiopterin or BH4. So if there's a deficiency in the PAH, then phenylalanine does not get converted to tyrosine, and therefore will accumulate in the blood and the brain. If it's untreated, PKU can cause intellectual delays, seizures, and motor problems. Due to the lack of tyrosine that's synthesized in the body, it often becomes essential, which means that tyrosine will need to be ingested through dietary means because it's not being synthesized in the body. The most common treatment for PKU is currently phenylalanine dietary restriction therapy, and phenylalanine is most commonly ingested through meats and dairy. Therefore, as a treatment, patients are encouraged to only consume a vegan, vegetarian diet. This means not ingesting any meat, milk, cheese, eggs, nuts, or bread. They also typically ingest a formula that includes all the essential amino acids and vitamins that their diet lacks to prevent a deficiency in any other essential vitamins and minerals. So after about 14 days on this therapy, patient A's phenylalanine levels did drop to 1.65, which is within the normal range, making this dietary change successful as a treatment for patient A. Here we see patient A and patient B, who is also suspected for PKU. They both received BH4 loading tests. And as mentioned previously, BH4 is the cofactor for the conversion of phenylalanine into tyrosine using the enzyme PAH. During the BH4 loading test, synthetic BH4 is dissolved into 20 milliliters of water in dim lighting. It's administered to the patient at least 30 minutes before a meal. And blood levels of phenylalanine are measured 3 times total. They're measured before the meal and then 4 and 8 hours after the meal. As we can see from this graph here, patient A and patient B both have similar blood levels of phenylalanine before their meal. After eating, patient A's phenylalanine levels increased slightly after 4 hours and then even more after 8 hours. For patient B, their levels actually decreased slightly after 4 hours and then drastically decreased after 8 hours. For patient B, their levels, this tells us that patient B is responding appropriately to the BH4 supplement, and so will likely not need to change their diet, but they can use this BH4 supplement as a treatment for their PKU instead. Patient A's phenylalanine levels were not decreased with the supplement, so their form of the disease is likely more severe and they will have to stick with the dietary treatment. So the reason why some patients respond to BH4 supplementation is due to where the mutation that's causing the disease lies. So as mentioned before, the most common place for the mutation to occur is at the PAH complex. This is likely to cause a patient A's disease, and so in this case, simply adding the cofactor BH4 would not make a difference. In patient B's case, the mutation is more likely to lie at the synthesis of the cofactor of BH4 itself, and so for this reason, the supplement of BH4 would be beneficial. The BH4 can have a large impact on patients like patient B, so for this reason, all PKU patients really should receive this BH4 loading test to determine if they would benefit from the supplement or if they should stick to the dietary regimen that patient A will have to follow. And that's it for case 2. So here are the resources for that, and that's it. Thank you.